Hello, and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, and we are streaming live from the Team Needham Abode podcast studio. And we are super excited to have Stefan Hartmann on our show today. He is a physician's assistant that has a direct primary care practice and has an interesting story about when he started it during COVID. So excited to have him on. As we wait to have him on, Janet, let's explain what DPC is, or direct primary care.
So for all of our viewers and listeners, you might have heard us talk about DPC, but the direct primary care model is a model where you can go to a provider, a doctor, a PA, ARMP, without the insurance model. So they work directly with you. And most of the time they have a different fee schedule depending on their demographics. So they are closely knitted to their community, which I think is very powerful because that's the piece of the puzzle I think that has been missing in our healthcare model for the last maybe 50 years or longer.
Stephen, welcome to our show.
Hello, hi.
Hello. So we were just explaining to our listeners and viewers direct primary care. So tell us a little bit about your practice in direct primary care and how it got started and when it got started. I think that's one of your most interesting stories.
Hold on a second.
I think that journey for a lot of physicians and practitioners like PAs and ARMPs are very interesting because usually they have a journey themselves. And also, I think, their personal gratification in their profession is much different. We've had many stories in the past, maybe 5 or 10 years, about people who have done this and how different it's impacted their lives as a person.
So, Stephen, direct primary care, tell us about it.
Yes, pronounced Stefan, by the way, so it's Stefan.
Stefan, okay, sorry about that.
It's German. I get it all the time. So, you guys want to learn about iron direct primary care or direct primary care in general?
Well, let's start with your journey about what I know you're pretty passionate about why you started direct primary care practice, and it was during COVID. We already kind of let the cat out of the bag, but tell us, what was the precipitating factor?
It was a sequence of very bad jobs and not being able to practice the right way to help patients. I mean, we were in the middle of the pandemic 2020, and I was practicing in urgent care internal medicine, and I developed the early treatment protocol, repurposing drugs, right? Before the pandemic even hit us, I was reading what the rest of the world was doing, learning about the mechanisms of action, and repurposing drugs. And so that's what I did when the pandemic hit us. I started giving all the patients early treatment. And at that practice I worked with, as a PA, we have these collaborating or supervising physicians. She didn't want me to prescribe hydroxychloroquine because it was too political. They wanted to, fly under the radar. I was like, it's not political. We're just trying to help people here.
Right.
And that was the first job. I ended up getting let go there because I wrote a mask exemption for a patient, and that didn't go over too well. And that was also too political to do something like that. So that was my first exit for a job. Then I worked in spine surgery. I was like, I'm completely going to get out of medicine. I'm just going to do surgery, right? But in surgery, I saw that, the patients were coming in with chronic pain, and it was just because their diet was terrible. They weren't hormonally optimized. They have a heightened inflammatory response. They were still getting vaccine injuries out there, and then coming to us in spine surgery with more pain, more inflammation. And, I got let go from that job just because they couldn't pay me. They couldn't pay me a PA salary because the surgical procedures were going down because the patient volume was going down. So the PA is the first one to let go. All right, Luckily, the whole time I had been working for a diabetes app. And the project was I was supposed to create a academic lecture every week to train patients how to reverse their diabetes naturally with diet and exercise, potential supplementation, And so I was really learning functional medicine inadvertently. I didn't know it was functional medicine at the time. I was just studying the mechanisms of disease, the pathology, how to reverse it with the tools available to patients out there outside of medicine. So that was really educational for me. And after I got let go from the spine surgery job, I got a job in psychiatry, which is as far from surgery as you can do. The PA profession is pretty cool. It has a lot of lateral mobility, right? One door closes, another door opens. So this job I got through one of my student rotations. They really liked me back there. And the physician who had owned the practice, he died suddenly, right? This is where we start seeing the died suddenly happenings. And I don't think the vaccine had come out yet, but he just, died suddenly, probably from the, just being metabolically unhealthy. So I came on and I inherited like all his patients, and I was having to manage all his patients that he had known for 20 plus years, 30 years of practice. And I came into that job as a contractor, and I was paid by the hour to see these patients, but I was still practicing functional medicine in psychiatry. So I was talking about their diet, their exercise, and I was suggesting supplementation. I was getting people off of their psychoactive substances, their benzodiazepines, their Adderalls, their SSRIs with lifestyle modification. But this wasn't appreciated by the supervisors. They were really mainstream supervisors, and they said, you need to follow the evidence-based medicine. We practice evidence-based medicine here in psychiatry. You have to follow. And so in psychiatry, evidence-based medicine is an algorithm. So the patient meets general anxiety disorder. So you prescribe this pharmaceutical. If it doesn't work, you go to this pharmaceutical. Maybe you can do a little bit of outside the box. You can repurpose Wellbutrin for like weight loss if the patient is, a little bit overweight. So there's a little bit of off-label use, but mostly it's by the book. And I got in trouble for suggesting supplementation to patients because this wasn't evidence-based, right? This was something as basic as vitamin D, a B complex for anxiety. This was suggesting that I wanted to test depressed men for low testosterone. And I was brought into a meeting. It was all virtual, mind you. I did this from my home office. Virtual meeting with the supervisors there and the collaborating physician who had just been brought on to supervise the PA fleet. And they said, if you think the male has low testosterone, why are you doing this in psychiatry? The primary care should have done this. Well, the primary care doesn't know anything about hormones, first of all.
Right.
Mm-hmm.
And they said, well, if you really think the man has low testosterone, send him to an endocrinologist. I'm like, what's an endocrinologist going to do? I mean, they manage diabetes, right? They don't do HRT. So I was stuck there, and I was like, well, am I going to just keep giving antidepressants to these people? No. But what really was the final nail in the coffin there was recognizing vaccine injury, because this was when the vaccine was rolling out, and I was taking a proper history. But for me, a proper history was also knowing what medications they may have started recently, a vaccine being a medication. But in mainstream medicine, they don't see vaccines as a medication with any sort of side effect whatsoever, right? So if you intake a patient and you say, well, have you started any new medications recently that would have precipitated your chronic pain, your depression, your anxiety, your suicidal thoughts? You don't talk about vaccines. I did. It was part of my assessment. And I found again and again patients getting vaccine injured and it precipitating or enhancing their underlying condition. In psychiatry, that underlying condition was depression, anxiety, bipolar, suicidal ideation, homicidal ideation. That's what I was seeing. And I recognized this, and I would have a weekly meeting with my collaborating physician. And she's like, well, how do you know this? I'm like, well, I just took a patient history. Well, can you prove this? I can't prove this. Well, you can't be associating this with the patient. So this is, this person was crazy. This was a crazy person. This physician, she wouldn't leave her home. I remember on a call with her, a UPS guy came to the door, and her daughter, she had scared her daughter about catching COVID so much. She's like, don't answer the door. Tell him just leave the package there. Super a maniac. And then another nail in the coffin was when I positively described the mechanism of ivermectin against COVID. I talked to this in confidentiality with a patient. The patient then talked about it with her psychologist and was very happy that I was talking about ivermectin, how it can be repurposed for all these mechanisms, actions. the psychologist reported me to the administrators. I had a meeting, and this is so dangerous. This patient could have taken ivermectin and they could have died. I'm like, what are you talking about? Ivermectin is one of the most used drugs on the planet. And they fired me. They said, you don't need to come into work next week. So all the patients I had next week, I was seeing 20 patients a day. They said, you don't need to come in. And that was also because they weren't paying me for the time I was putting in. I was a contractor. I was supposed to be paid by the hour. They stopped paying me for doing administrative duties. So I would be there 2 hours a day doing refills, doing prior authorizations. And they're like, you're not getting paid for this. I'm like, I'm a 1099 contractor. You're not going to pay me for the 2 hours I'm sitting there doing admin duties? They're like, no, you should be doing that during your work. I'm taking the patient and I'm taking their copay. I'm seeing a patient, I'm assessing them, I'm diagnosing, I'm refilling medication, and then I'm putting the ICD-10 codes in and billing their insurance all in 15 minutes. And I had to see at least 20 patients a day with a 1 hour lunch break. This is impossible to do. It's an enormous task. And like being empathetic to patients who are very depressed, they're locked down in Massachusetts, they can't leave their home, all this fear, it's absolute nuts. And so that I was like, geez, by that time I was like, wow, this system is so corrupt. I can't do any right by any patient because my hands are handcuffed behind my back by all these idiots in charge. I need to either quit medicine entirely, just go back to tennis coaching and personal training, or, go into finance or something, or I have to find a way out. And so I knew I had to start Iron Direct Primary Care. It was a new movement at the time. DPC was in the infancy stages there. There was no DPCs in Brevard County except one other one. And so I learned about it. I was like, this is it. But the challenge was finding a collaborative physician who, in Florida, we still need a collaborating physician to, be a name at the state at the very least. And so it took me a while to find one. I eventually did find one, which is actually the first physician I ever met through tennis in the early days. And so I worked random urgent cares all throughout Florida to make ends meet. I was seeing 120 patients a day in these Advent Health urgent cares, and I was a top performer there. I was knocking it out. And this is something that I also want to bring to your attention is my encounters there with pharmacists. And I want to put this question on you guys. I had some pretty bad interactions with pharmacists because I was, again, early treatment. And I was giving all the patients my supplementation protocol for early treatment. And I would prescribe hydroxychloroquine. If I prescribed hydroxychloroquine to Walgreens or CVS, they would report me to the administrators at the urgent care and said, now this doesn't look like it's a refill for lupus or arthritis. This looks suspiciously like it's for COVID treatment. So the pharmacist felt like they were God's gift to earth to make sure I wasn't prescribing hydroxychloroquine. And this is at Publix, CVS, and Walgreens. Different pharmacies, different pharmacists, they all felt like they were the guardians against using hydroxychloroquine. Can you explain that one to me as a pharmacist?
Well, so, Janet and I have been in the health and wellness space, out of the typical traditional pharmacy model for over 2 decades. And one of the reasons why is because of the things that you were discussing. We realized the whole system was a scam, and that pharmacists are used as pawns by big pharma to dispense poisons for big pharma and then collect copays for insurance companies. And we were kind of where you were at. It's either we change our practice or we get out of pharmacy. And I will tell you, most pharmacists, I'm just telling you, this is the truth. They have so little power in their own job. They don't even have the power to turn the lights on and off. And there's a true story about that. So anytime they get a little bit of power to flex their muscle, they're going to do it whenever they can. And that's a typical pharmacist for you. Now, that being said, I will tell you, I don't know what happened in Florida, but in Washington State, we as pharmacists received a letter from our state board of pharmacy saying, if we see any inappropriate prescribing habits, feel free to turn them into the appropriate licensing board. So it was, as you know, it was a coordinated effort, not just nationwide, but worldwide to, roll out, the whole scamdemic, just like you said, was a coordinated effort, the whole thing.
Well, in my opinion, too, it's a team effort, I think, between multiple facets and layers in the healthcare system. But as a pharmacist, I believe that was really sad from my perspective because most people don't realize how much off label is actually being prescribed or used. So it was just a hyper vigilant time where, you're turning into, you're going to report somebody because they're not acting the same way that you are acting or think you should be acting. And quite frankly, in healthcare, we should be embracing options and what's working for somebody else, but it's kind of a group think happening. So it's unfortunate, but we could go into so many different therapies that have hit to that level that, it just seems so extreme during COVID.
Oh, extraordinary extreme. And so what I ended up doing is I would write ivermectin prescription on a piece of paper, and I found some trusted pharmacists in the community, and I said, all right, take this one, go to them, and they'll fill it for you. But we
Right.
had to do it under the radar so I wouldn't get in trouble. But I got in trouble for other reasons too. I wouldn't wear a mask in the urgent cares. I would like dangle it around my ear, and the administrators were watching me on the camera. And so they would text my locums agent and they're like, can you talk to Stefan? He's not wearing his mask. And I'm like, so I'd wear it around my chin, and I'd go into a patient's room and I would take it off immediately. And I'd say, you can take off your mask right now. And the patients were so happy. And sometimes they were a little bit fearful, like, oh, aren't you worried? I'm like, I've been doing this since the early days of the pandemic. I haven't got sick yet. I'm fine. Don't worry about me. Breathe. And there are oxygen.
Crazy times. So fast forward, you open up Iron Direct Care, and what was your goal with Iron Direct Care? How did you want to be different?
I wanted a way to free myself from the system and free the patients as well, to actually help people without being burdened by administrators who thought they knew what was best. I started it out of my house. I did house calls and telemedicine because, I was broke. I didn't have much money. I just had student loans really and the mortgage. So the key is like keeping overhead low. I watch these DPC communities on Facebook. I know you're part of that group. And they're like, should I buy an EKG machine? No, don't buy the EKG machine. You don't do that, especially when you're first starting out. You keep the overhead as low as possible because that's, you bring on patients, you keep the prices low, and you grow from there. And now we're doing really well. We have over 1,000 patients, and it's grown beyond just me. I have another PA and another nurse practitioner who accept patients. And we have a pretty cool office building on the beach with a bunch of cool regenerative technologies here. And now I bought the cool toys, but don't do that first. That's the pro tip.
So tell us about the direct primary care model, the monthly subscription model without insurance. We were kind of getting into that when you first logged in.
Yeah, it's basically Netflix for your primary care is what the elevator pitch is. You pay every month for Netflix. You don't need to watch, Breaking Bad, but you can binge watch it if you need it. The same applies to primary care. Patients pay us every month, whether they use it or not. But if a patient needs to come in every day because they have a serious infection and I need to give them IV Rocephin, we do that. And there's no additional charge for that other than the basic supplies. Right. So we take care of patients. It also allows, that administrative burden I was talking about in psychiatry that they weren't paying before. That's a huge problem in medicine that patients aren't really aware of, is how much back end work it takes. And we're not reimbursed for it. So in a conventional practice, you can't bill for, picking up the phone when a patient is really worried, about their little baby who's having some trouble breathing. You don't get paid for that. Right. But under the membership model, that's all covered. They can text me for any rash. They can send me a picture. I get crazy pictures sometimes. There's no problem. Send me a picture. I'd rather you send me a picture than worry. So all of that is covered under the membership model. And then, of course, all visits are covered and any questions they write in the portal is covered. So all this stuff is covered, which is really a huge burden off of the provider. And administer, and it keeps costs a lot lower as well because we don't need a billing department. We don't need a real secretary to book patients. We don't need to take payments. It's all just done automatically.
Well, it must be to have 24/7 access to a physician's assistant must be super expensive. So what kind of fees are you charging?
I started out really affordably to grow it. You can sign up now with a PA or my nurse practitioner. It's $100 a month for one patient, and it gets much more discounted if you join as a couple. It's like $140 a month, and then a whole family. Like we had a family of 8 sign up with my nurse practitioner, Jason. It's $180 a month. So for 2 parents, 6 children, flat rate, that's a great deal, and it helps a lot of big families.
So I mean, it's just so affordable. It really is.
Right.
So I know we follow some of the same DPC groups, and I think you think along the lines that we do. That's one of the reasons I had you on the podcast. I think you might agree that, because of COVID, there's a lot of things that were exposed, and that was great. We knew and you knew there was a scam in the system before COVID, but COVID exposed a lot of them. It also made a lot of physicians and other physician's assistants, ARNPs, realize that also, and they went DPC. So DPC really grew during COVID. That was a good thing. I will say this, and I want you to discuss this and what makes you different. There's still a lot of DPC models that they're still very, very traditional. Mm-hmm. Oh, your cholesterol's 201. You need Lipitor. Right. They're not checking testosterone. They're not checking thyroid. Or they're not optimizing them at least. So, what are your thoughts about some of the traditional DPCs that are kind of just being drug dealers and not actually healing people?
Yeah, I mean, the market should decide if they really want to pay for that. I mean, insurance can cover that sort of care if you want that sort of care. You don't need to pay cash for it. But I guess there is some benefits that you can maybe text them and they can give you an answer. So that's pretty cool. It would be great if they took some extra courses like I did. I've spent a lot of money and time continuing my education beyond PA school. PA school is great because it gives you that, that allopathic training where you know how to treat and you know how to diagnose. It's actually very simple. It's not super crazy to learn. I mean, it's hard to learn in school when you're a student, but then outside it's very algorithmic and easy. It's a brainless way to practice medicine, but it's the evidence-based way, right? It's what they call evidence-based medicine. It takes a lot of more cognitive bandwidth to practice functional medicine, where you're looking at things in a layered approach to optimize the patient. DPC is the best way to do this because you have a lot more time. You don't need to see so many patients a day. So you have more bandwidth to focus on the patient. So I feel like patients do need to vote with their dollar still. If you're taking cash rates, that's the free market economy. And I think we're here educating patients that they do need to demand better from their providers, whether it's DPC or conventional or insurance-based medicine. But if they're giving you that same nonsense that we saw in the pandemic is take Tylenol for your flu and go to the hospital or an urgent care if you're worse, or call me if you're worse, that's not it, right? We need to be more proactive with repurposing drugs for early treatment, but then we also need to be optimizing the patients so that they don't get sick. If we have a patient who's sick, what do we want to do? We want to make sure their diet is clean. We want to make sure all their vitamins are optimized. We want to make sure all their hormones are optimized. So, take, for example, optimizing DHEA. If you look it up, decreases colds. Same with testosterone. It modifies the immune system, so it's not so polarized towards hyper-inflammatory responses. So that's what needs to be done. It takes a lot of effort, takes a lot of additional study. I'm hoping to educate my colleagues in DPC. I've created a course, the Learn Functional Medicine with Iron Direct Primary Care course, and I can teach hormones in 10 hours, female and male hormones. So it can be learned very rapidly.
Well, I think too, one of the things that Shawn and I have focused on over the years that we've done the podcast is that, really the pandemic in the United States is cardiovascular disease and obesity and everything else that follows through that. And how often do you see clients coming to you where nobody has ever addressed anything in their lifestyle? I mean, obviously, if you have an animal or a pet, the first thing they do is ask you, the vet asks you, what are you feeding your animal? What are you, what kind of exercise? They look at how this animal is existing, which should be maybe the first step. So I don't see, without changing how we approach um, our healthcare model, how we're going to change this real thing that's happening in our culture. Because Americans, life expectancy is dropping, and their quality of life is dropping. So how do you see your practice playing in to help that? Because I think that to me is the cornerstone of what you're doing.
Yeah, when I started out, I was doing house calls and looking at the kitchen inventory to see what Americans were eating. And what I found was that Americans are consuming mostly ultra processed foods. They'll start out with a Cheerio breakfast. Kids will go to school and eat a school lunch, and that's usually junk processed foods, hot dogs, pizzas, and so forth. The parents might work and then order out, and they get Subway sandwiches. The most nutritious food I found that the family eats is at dinner. They make some meatballs, or they might, if you're lucky, bake some salmon. So I found okay, they eat at least one meal a day that's nutritious. It's in the evening typically when they have time to sit down and cook. The rest of the day is junk. So that's 70% of the food that Americans eat is ultra processed junk food. When you have 70% of your body made out of junk, low nutrient status, no wonder you're chronically inflamed, chronically sick. But I found that patients are so chronically inflamed and chronically in pain. Their brain is all balled up. They have all these thoughts in their head. They can't get their brain to turn off. They can't sleep. They don't even know what it feels like to feel good. They don't have a baseline marker of what is good, what is healthy, what it feels like to be normal. So when you take a patient in, you need to really look at the diet and say, well, we need to clean this up here. And then you need to look at all the hormones. You need to balance the hormones, and then look at the nutrients and the gut. It's a layered approach. It takes some time. But the problem I still keep encountering, even after years of doing this, is that patients perhaps don't understand how important the lifestyle is, right? We have a whole gym in our backyard. They know I eat clean, and they know the diet is important. But I think they're like, yes, because they've never actually experienced what it feels like to feel good with a relaxed brain and no pain. So that's still a battle we need to fight.
For sure. I think in some ways too, we can blame on the medical system too, because we give them a pill for every ill. Oh, you've got reflux. Okay, you need Prilosec. Oh, you've got type 2 diabetes. Well, you must have a medication deficiency. No, your type 2 diabetes is caused by your diet. So in some ways you can blame the medical system. And I know that a lot of doctors will say, well, patients aren't going to follow, dietary guidelines or lifestyle changes anyway. And in my opinion, Stefan, that's a lazy doctor. That's a lazy doctor just copying out, saying, just prescribe a pill.
It's true. I was raised differently. So when my parents didn't bring me to a pediatrician, I never had a well child check. I haven't had an antibiotic to this day, and I didn't have vaccines until I had to go to PA school. Then I had to take one for the team and catch up. When I was sick as a child, my parents would say, well, what did we feed the child? It was just like if you had a horse, like, is this horse sick? Well, what is the horse eating, right? It's the same concept. And they would look at the diet, and they would fix the diet. Oh, he ate junk food. He snuck some candy. Let's fix that. So that's how I was raised. And that's how I try to educate my patients, is to look back at the diet. Oh, you have back pain. What did you eat? Oh, back pain has something to do with what I ate? Mm-hmm. Yes. Okay. I got sick. I had this recurrent congestion. All right. What are you eating? Are you eating junk? That's the first place where you need to start with everything. What are you eating? But it's foreign to everyone, really.
Yeah. And, back on evidence-based medicine, let's just call that what it is. When we say standards of care in healthcare or evidence-based medicine, let's just talk about who puts out the evidence and who puts out the standards of care. And it's drug companies colluding with insurance companies to create evidence-based medicine and standards of care. Those are just facts. And those come straight out of medical schools and pharmacy schools too.
Yeah, and the diet is completely separate from everything, right? When you have a patient with anxiety and depression, when I was approaching these patients in psychiatry and asking them about their diet, that's not part of any standard of care in psychiatry at all. That's what I was doing was not evidence-based medicine. Got in trouble for it. So
yeah,
but it's shocking that if you have I since we focus on hormones, I ask somebody sometimes, like, why were you put on that antidepressant? Well, my spouse died. Well, okay, aren't we supposed to feel those emotions and get through, the grief process rather than being numb? But now 20 years later, you're still on the antidepressant. And that's the trap, I think, that people live with, is that, we give you a pill to solve something, but it also creates, and you know this as well as I do, that it creates then, okay, well, now I have problems sleeping, or now I have problems. So I'm going to add one more. And then pretty soon you've got 10 or 20. I mean, the amount of prescriptions that Americans consume is far more than any place else on the planet, and we're the sickest.
yeah, that is an odd one. I was just in Italy. I gave a conference at the Italian Functional Medicine Symposium, gave it in Italian, by the way, on brain optimization. And at the end of the conference, I heard a lot about ultra processed foods, and some of the slides the Italian doctors were presenting looked like American foods. I was like, all right, we're getting called out here. What's going on? So at the end of the conference, they brought up all the speakers, and I asked them, I said, all right, saw the American foods on the slides, but what about Italian foods, right? Is a pasta an ultra-processed food? And they were like, no, it's not. When it's made at home, it's done properly. There's no glyphosate. It's al dente. This is not an ultra-processed food. But the Italians, from what I've learned, they have shifted the Italian population away from eating too much carbohydrate and eating more protein. So one of the simple things you can do when you're in Italy is you can order a secondo, which is the second course. Typically, a second course in Italy is higher in protein and vegetables. So when I went out to dinner with some of the Italian doctors, that's what they did. Instead of a first course, which is a carbonara or a high carbohydrate meal, they would order the second one. So Italy, the population does seem a bit healthier from my observations. First of all, there's no urgent cares on every street corner. And their diet does seem to be a little bit better, but even there, they are trying to shift them away from the high carbohydrate, brioche croissant in the morning. And so that's happening there too, but it's worse in America, of course.
Yeah. We just, like you said, the most important thing that we probably do every day is what we eat. I will say that sleep is more important, I think. But what we put in our bodies when we eat is the most important. I mean, a lot of people think it's exercise, which is very important, but you can't exercise your way out of a bad diet. So, I mean, what we eat is super important. I used to not believe, many years ago, well, how could diet affect our mood? How could it affect depression? How could it affect bipolar? And now it's just, first of all, I've seen so many anecdotal examples of people that change their diet and they're not depressed anymore. So, and I don't care what study, if there's studies out there or not, I don't trust the studies anymore. I just see it with clinical experience that when people clean up their diet, many diseases, including mental health issues, are reversed.
Yes. Right. I saw that a lot in every specialty I worked in, whether it was urgent care. I would always ask about the diet in an urgent care setting. I was like, what are you eating? Oftentimes I'd find out that's a vegan diet or it's an ultra processed food diet. That's why they're having all these symptoms. They're so fatigued, they're injuring themselves. Then in psychiatry, I would link the diet back to their mental health. And then in spine surgery and pain management, I would find out their SI joint inflammation, their chronic pain. If we fixed their diet, their pain would get a little bit better too.
Yeah, imagine that. Right.
So
as we wrap this podcast up, Stefan, tell us a little bit about your website, how people can get a hold of you if they have any more questions.
Right. So I'm easily findable on social media. I have a Spotify podcast. I just released a talk today on the scandemic. It's a scandemic history. So you can find it Iron Direct Primary Care, Spotify, and YouTube, and same on Instagram and even TikTok, mind you. But if you're looking to become a patient, you can come to irondpc.com and you can register with one of us at the practice. It's me, Lauren, and Jason. We're the providers here. I have licenses in various states, Utah, Iowa, Montana, and Florida. Lauren's licensed in Wisconsin as well. Jason primarily sees families here in Florida, big families, mind you. He sees all ages. If you are a provider looking to learn this sort of thing, I do have a course. I'll probably put it up on the website later because I just launched the male hormone optimization. So you can learn how to do that in less than 5 hours. I intend to launch female hormone optimization by the new year. So you can learn how to treat female hormones within about 5 hours as well. So I'm hoping our DPC friends start optimizing all the hormones, and they're going to have so much more success in their practices, both patient outcome and financial success, because patients will be happier and they're going to stick with the practice if they're actually getting real treatment.
Absolutely.
Right.
And that goes, I want to mention too, one thing I think is important as healthcare professionals is that we need to be good role models. And that's one thing when I follow you, I realize that you are, you are healthy looking yourself. You work out, you eat well. And most healthcare professionals, I mean, we are in our professions, we are the worst examples of health. If you want to see sick people, go into a hospital lunchroom and look at all the sick people that are workers there eating lunch. It makes about as much sense to me as a dentist that has crooked yellow teeth. Nobody would ever go to a dentist with crooked yellow teeth. So why would they go to a healthcare professional that doesn't look metabolically healthy? I mean, seriously.
They are the sickest people sometimes. I mean, especially when they're doing shift work, they're stressed. The shift work itself destroys the hormones. I treat paramedics here all the time. They're on 24-hour shifts. Their testosterone, that ship has sailed. The testosterone doesn't know when to cycle. The cortisol doesn't know when to cycle. So in these individuals, if you're stuck and doing the Lord's work on the streets as a paramedic doing 24-hour shifts, honestly, you need hormone replacement therapy. There's really no way around it if you want to actually feel good. The same goes with, BAs, doctors working emergency medicine. Those shifts overnight, they wreck you metabolically. There are some non-modifiable risk factors for being a healthcare professional, but you've got to do the best you can. I mean, I know when I worked in the hospital doing overnight shifts, I didn't make any excuse. I still hit the gym. I brought all my meals, and I was eating fish in the ER. Sometimes I would get funny comments like, "Smells like BV." BV. Yeah, I got that one.
Oh, wow. Well, Stefan, thank you so much for being on today. You've helped us realize our goal of this podcast, which is to educate and empower individuals to take charge of their own health. So thank you so much for being on today.
Great. Thanks for having me, guys.
All right, let's stay in touch. Bye-bye.
Cool.
And listeners and viewers, thank you for tuning in to Health Solutions with Shawn and Janet Needham. Tune in Monday to our regularly scheduled podcast, 12:30 to 1:30 Pacific Standard Time. And a happy Thanksgiving to everybody. Thank you.